So what are antibody-drug conjugates? So we've got sacituzumab govitecan, we've got datopotamab deruxtecan, and sacituzumab tirumotecan. Essentially, they're all TROP2-directed drugs, but they differ quite substantially. So they differ in their drug-antibody ratio, they differ in their linker technology, and they differ in their payload biochemistry. And that's really important because it therefore shows that they've actually got different efficacies. They've got different toxicity profiles, which you will see later on in the talk.
The first trial is the EVOCE-01 study with sacituzumab govitecan versus docetaxel. You can see that the patients have a similar overall survival curve, but at the end, this is a negative trial. With datopotamab deruxtecan, same population, second-line patients, TROP2-01 is again randomization between Dato-DXd versus docetaxel. This was a dual primary endpoint, PFS, OS in the ITT population, and this is a positive trial. We see here, looking at the histology subgroup, that the benefit is driven by the non-squamous, and that the squamous cell carcinomas do not benefit from Dato-DXd, and the subsequent development of Dato-DXd in lung cancer is restricted now to non-squamous cell carcinomas. The adverse events of special interest include stomatitis, ocular events, and ILD, and this will be further discussed later in this webinar.
I think the question is whether or not these ADCs with IO will replace IO monotherapy in PD-L1 more than 50%. I think the question is whether or not we feel we need to intensify treatments, or really do we take a more clever approach of actually selecting our patients to see who needs what. For me personally, whether or not this survival improvement justifies the added toxicity that I'm giving to my patients, and that's important. And really where all these ADCs are going to sit and how we best position them.
And from a toxicity signal, we see sac-TMT and Dato-DXd both causing mucositis, stomatitis, which we'll discuss, as we don't see that as much with sacituzumab govitecan. I think the interesting thing to me in this is that I think of these as being very much TROP2-directed toxicities. Now, a grade 1 is not necessarily symptomatic. So it's just to point out that even not all grade 2s really need to be dose reduced or even dose delayed. But there are things that you can do to potentially help reduce this. The easiest is the good oral hygiene, gentle brushing, daily flossing, a bland rinse, being well hydrated. And things like the corticosteroid-containing mouthwash, using an oral mouthwash that's a steroid.
All right, so I'm going to be covering ocular surface events. They're another important toxicity class with TROP2 ADCs, especially Dato-DXd. Fortunately, many of the events are mild, but they require vigilance because the symptoms can escalate if they're ignored. So common symptoms that we see, mostly dry eyes, excessive tearing, blurry vision, eye irritation, maybe some light sensitivity. We should be getting baseline eye exams for patients, especially on Dato-DXd. For grade 2 or higher ocular surface events, we are referring to an eye care specialist. And it's important that you understand that it doesn't just have to be an ophthalmologist. As far as prophylaxis and monitoring, prevention and monitoring, they are key components to ocular toxicity management. And then patients are using artificial tears and lubricating preservative-free eye drops, starting with the first treatment.
Now, the big thing about ILD, one is identifying it early. If you see something that you don't have a better explanation for, I think you really have to consider this to likely be ILD, but one needs to really be aware. Essentially, the short of this is there are higher degree steroids for higher degree suspected ILD, but multidisciplinary workup is really important.
SASI-G is kind of particularly associated with diarrhea and neutropenia, consistent with that SN38 payload. Dato-DXd kind of has a different toxicity pattern.
I mean, clearly, there are a very promising therapeutic group of drugs that are coming across the landscape of non-small cell lung cancer. And, we're seeing, consistent but manageable safety profiles as illustrated by Jacob and Stephanie. Thank you, everyone.
Thank you.